And the next topic is a timely concept, that is advances in basal insulin therapy. And to speak for this particular session, I would like to invite Dr. Subir Ray, who is a senior endocrinologist. And to chair this particular session, I would like to invite Dr. Ajay Biswas, who is a consultant physician and endocrinologist. Along with him, I would also like to invite Dr. Shankar Nath Jha, who is a consultant physician. Speaker, sir, and chairperson, sir, kindly be on stage.
It's always a pleasure to listen Dr. Subir Ray, a wonderful mix of wit, wisdom, and known for very clarity of thoughts and take-home message. Over to Dr. Subir Ray. We are running late, so we will not be wasting time.
Good afternoon, everybody. I'm going to talk about Gen 2 basal insulin. This part of the program is sponsored by Sanofi, so I'll be talking about the Sanofi's Gen 2 basal insulin, that's Toujeo or U300 glargine. Of course, I'll try to make it as scientific as possible and as neutral as possible so that you don't feel that there's a smell of bias coming from it all. So timely concept and advances in the basal insulin therapy. So how many of you use basal insulin as a first or initial insulin therapy? Can I see a show of hands? Right, okay, so you're kind of not shy. But the thing is, I am a basal person. I use basal insulin as the first insulin of choice. And there are reasons behind it. So I'll try to touch upon the evolution of basal insulin so that we understand why we needed new generation basal insulins. Then I'll just discuss a little bit about the evidence that's been generated over the years supporting the use of Gen 2 basal insulin. So why do we need Gen 2 basal insulin? Why do we need a basal insulin at all? We want the Gen 2 basal insulin or a proper, true basal insulin or an ideal basal insulin which works longer. At least it covers the whole day. If it does not cover the whole day, what's the point of calling it a basal insulin? All right? Less fluctuation. Many times your patients will come and tell you, Dr. Babu, sugar to fluctuate. So you want all insulins to work the way you want them to work. So you want the basal insulin to work as a flat insulin, not ups and downs, no vibration, no fluctuations, okay? You want it to be effective. So if it is not effective, there's no point using it. While you are trying to make it effective, while you are trying to bring the HbA1c down, bring the fasting sugar down, bring the pre-meal sugar down, you do not want unnecessary hypoglycemia. Why? Because hypoglycemia is bad for the patient's psyche. If it is not killing the patient, it is actually disturbing his mental peace. Okay, and we want the patient to achieve glycemic target without too many bumps, all right? We want it to be safe so that we can use it across the board. We can use it in elderly people, we can use it in pregnant people, we can use it in a patient who has got cardiovascular problem, we can use it in a patient who's elderly. Okay, so I should be able to use it for my mom who's 84 years old. Okay, we want the insulin to be flexible because flexibility is one thing the patients always want. They do not want to be tied with the clock. They do not want to take the insulin the fixed time of the day because our life is not actually very rigid. So we have to give them kind of flexibility. It has to be less painful. Injection never kintu batha jano na hoy rakhte ho. Okay, so it has to be less painful. And I did not mention if it is less costly, better. So these are the aspects. These are the features we want a true ideal basal insulin should have. So how did it evolve over the years? If you remember, insulin was discovered around 1921-22. We all know that insulin, the endogenous insulin, is a hexamer. It's a triplet of two dimers joined with zinc, and then liberated from the secretory vesicles of the beta cells, then get dissolved and work as a monomer. So when you inject, it doesn't work that way. because a normal physiological insulin is a trickle all the time with a peak when you are eating. But when you inject in the subcut space, it doesn't work the way we want it to work. Particularly, it does not give you the basal trickle supply. Okay? So there was a lull for the next 30, 40 years, a lot of experimentation with initial animal insulins, then recombinant human insulins, adding different materials like zinc, etc. Did not work. First breakthrough came with NPH insulin. It's a kind of a protaminated insulin with a zinc, okay, 1:5 ratio. It worked to some extent, but the problem was, it was not a true long-acting insulin. It works for not more than 10 to 12 hours, and it has got a prominent hump, okay, after 6 hours of injection. So it is not a flat insulin. It is not a long insulin. It is not devoid of hypoglycemia. Only good thing is we did not have anything else to offer, so we used it. Is it out? No, it is not out. It's down, but it's not out. You still use it. Okay, in certain situations, if you can negotiate those humps and all, you can still use it. And we are still using it in our hospital. Okay, it is probably the only properly recommended intermediate insulin or a basal insulin in pregnant patients. Okay. After, again, a lull of quarter of a century, we had the first analog basal insulin in form of U100 glargine. So you replace glycine with arginine, add a couple of arginine in the second chain, and you get the glargine, which works through post-injection precipitation pathway. After getting glargine, you thought, okay, we have got the perfect ideal insulin. To some extent, it is probably true. We still consider U100 glargine as the gold standard insulin. It works almost 24 hours, if not a couple of hours short, but you can probably negotiate, except probably in some cases of type 1 diabetes, where you might have to give it twice a day. Is it almost a flat insulin, but not truly peakless insulin? It has got a peak around, say, 12 hours after the injection, but it's not as prominent as the NPH insulin. So it is fairly long. It gives you almost 24 hours cover. It is almost flat and is very, very effective. So it was a gold standard insulin. We had Levemir insulin came a couple of years later. Again, the problem was it was probably as flat as glargine, but it was not as long as glargine. It does not work that long. It probably works not more than 17, 18 hours. So it kind of fell short of around 4 or 5 hours before being called a true 24 hours acting basal insulin. So we were kind of happy with whatever we had for the next 10, 20 years before we had back-to-back development of 2 Gen 2 basal insulin. One is U300 glargine, we call it 2GO, and then we had insulin deglutide or Tresiba from the Novartis. Okay, I'll leave Tresiba out today because I'm going to talk about 2GO insulin only. So how 2GO was different, how U300 glargine was different from U100 glargine, because it is concentrated glargine. It is 3 times more concentrated. Naturally, whatever injection you're giving, is the volume is small. If the volume is small, the surface area is small. If the surface area is small, the absorption is slow. So it is giving you, two basic purpose, okay, just because of the size. It is giving you a longer absorption time, making the insulin pretty prolonged, and it is giving you less volume to inject, so the subcut shearing force is much less, so the patients get less pain, particularly when the volume is much. Okay, so if you're giving somebody, say, 40 units of insulin U100 glargine, it's a big volume, so 1 ml, and you're giving it in the subcut space, it's tearing the subcutaneous tissue. Many patients will come to you with, say, blackening and bruising and all those areas because the patient was injecting big volume of injection lantus. So 2GO solved those 2 problems. 2GO, can it be called a true ideal basal insulin? It has tried its best. Okay, there are loads and loads of studies over the last few years. It has got PK/PD study proving that it's really a true flat long basal insulin. It has got addition program where it pitted U100 and U300 glargine against each other to show its efficacy and safety. it has got the real world study to show that the flexibility part, the true 24 hours acting, it really works and works safely. It has got few programs against the compatriot, that is Tresiba insulin, to show that it is probably as good as Tresiba, probably better in some areas. So it has done its bit to try to check all the boxes that is required from a true basal insulin. So this is the PK/PD data, which shows that insulin U300 glargine works longer, works flatter. Okay, so it is a flatter than U100 glargine. It works longer than U300 glargine. The half-life of U300 glargine is around 20-22 hours, so it gives you a pretty long half-life, so it covers the whole day. And that gives you a flexibility of a couple of hours as well for the injection. Regarding the safety and the efficacy program, it was pitted against its elder sibling, that is U100 glargine, in different programs. That's edition 1, that is basal bolus. Edition 2 is basal only therapy on top of OHA. Edition 3 is basal only therapy on insulin naive patient. And then you get the programs of the type 1 diabetic patients. Okay, so it kind of check the efficacy and safety against the so-called gold standard U100 glargine, and in those programs, particularly in the patient level meta-analysis of the pooled data, showed that it is not only effective, it gives you less hypoglycemia and probably half a kilo of less weight gain when compared to U100 glargine. A TOF study is a real-world study. I was a part of that study, and it showed that India was a part of the study. A couple of thousand patients from India was included in that program. It's a global study. It showed that in India, the real-world scenario is pretty bleak. 1 in 3 patients were not under control. But using Toujeo as a basal insulin of choice, changed the scenario within a year. And that's 25% patients that achieved HbA1c of 7% or less within 6 months. Around 45% patients that achieved the target HbA1c of less than 7% in a span of 1 year. The HbA1c dropped by almost 2 marks. So in across the real-world study, Toujeo showed that it is effective in the real-world scenario to bring more and more patients in the target range. BrightSide is a head-to-head study between two Gen 2 basal insulin. In general, I would say there was hardly any difference between these two Gen 2 basal insulins. But in the initial 12 weeks time, there is a titration period. Toujeo, that is U300 glargine, showed that it is slightly safer. HbA1c reduction-wise, there is no difference at all. Both the insulins, they came out with flying colors. So head-to-head study with insulin deglutide, U300 glargine showed is absolutely effective, not inferior at all, as long as HbA1c reduction is concerned. Hypoglycemia is a real issue. It doesn't matter how much we try to trivialize the incidence of hypoglycemia. It's a real issue in some situations. It makes the patient's quality of life pretty bad. It can trigger cardiac arrhythmia in patients who are susceptible, who've got comorbidities like cardiac problems. So we try to avoid hypoglycemia if we can, while try to bring more patients under the target range. There has been few trials, few reports. Deliver2 is a real-world study where people with type 2 diabetes were switched to U300 glargine and showed less incidence for hypoglycemia. Additionally, I've already talked about where U300 glargine showed to be effective with less hypoglycemia. And in BRIGHT study, as I already said, that it gives you less hypoglycemia. I'll just elaborate a little more. Addition and BRIGHT. In addition, you can see there's a 23% less hypoglycemia compared to U100 glargine. In BRIGHT study, in the initial 12 weeks titration phase, there is 43% less all-time hypoglycemia and 35% less nocturnal hypoglycemia. CKD patients are actually one pain in the back for insulin therapy. It always makes us slightly jittery whether those patients are going to get hypoglycemia. If the patients get hypoglycemia when they've got the background of renal impairment, it makes a pretty tricky situation. They may have a pretty bad outcome. So we have got quite a few post hoc meta-analysis of some of the trials, like in Edition, Deliver, Bright, Ethos, where they looked at the patients with renal impairment, and in all those trials, U300 glargine should be safer in terms of giving less hypoglycemia, because we believe that bad hypoglycemia is pretty detrimental for the cardiovascular health for those patients. This is again just highlighting the Bright result. This is the initial titration phase. You can see the patients with renal impairment, they had better HbA1c reduction, but they did not have more hypoglycemia when treated with Toujeo or U300 glargine. Elderly patients is another tricky group where we do not want hypoglycemia, because the most important problem in managing elderly patients is basically prevention of fall. We do not want them to fall at all, because one fall is basically the fractured neck femur or some bad fracture, and that is a killer, okay? So we want them to have as little hypoglycemia as possible. Okay, they do not want complicated insulin therapy, so a basal insulin with less prick is actually ideal for them. There are quite a few trials, quite a few RCTs, like senior RCTs or Edition 1 to 3 program, or Bright RCTs. In all those programs, U300 glargine showed that it is safer in terms of hypoglycemia while giving decently good HbA1c control. Same was reflected in Ethos and Deliver, which were real-world trials. This is just a snapshot of what we do in pregnancy. There is a few questions whether U100 or U300 glargine can be used in pregnancy. Yet it can be used in pregnancy. If you think it is indicated clinically, you can certainly use it. Regarding fluctuation or variation, there are a few trials from U300 group, mostly CGM or the flash glucose monitoring trial, to see whether U300 treated patients are staying more time within the range, giving you less hypo, less hyper, which makes the life of the patient fairly comfortable. It's a Japanese trial by Kawaguchi. It's a CGM trial, and it showed that comparable, it's a better performance with U300 glargine with less time below range, so less hypoglycemia when compared to insulin degludec. This is a flash glucose monitoring study. Again, you can see that the percentage of time in the nocturnal hypoglycemia with U300 was less compared to the other insulin. This similar is a one-care trial, a real-world trial, giving you the similar kind of thing. Nocturnal hypoglycemia was particularly less frequent in U300 glargine. These are the couple of trials showing that it can certainly be used effectively, even if the injection time is a couple of hours here and there. So as long as the patients are taking it, roughly at the same time, there is hardly any problem, which is slightly difficult for U100 glargine, which needs to be given at a particular point of time every day, no matter what. So this gives you plus minus 3 hours of insulin injectable time. So if a person is usually take it, say, at 10 o'clock at night, if the person is going for a dinner somewhere else, he can come back and take it at 11 o'clock without affecting the overall performance of the insulin. And similar experience was seen in other trials, like take control trials, where the patient's self-control or self-titrated insulin of U300 glargine was better performed when compared to physician-led titration. Similar in Edition 1 and 2, when they followed up for another 3 months to see whether it's plus minus 3 hours of insulin therapy works, it does. So Gen 2 basal insulin, U300 glucose, has made certain changes in our perception of basal insulin. It is giving full day coverage. It's a once-a-day injection. There's less hypoglycemia, less weight gain. It doesn't matter whether it is half a kilo or not. At least it doesn't push the weight up. The dosing is independent of the meal time. It can be taken before, after, or with meal. Improved quality of life and the patient satisfaction, because the patient is getting 1 injection a day, less painful, less volume, so naturally better adherence. And we all know that compliance is equivalent to complications. If the patients are compliant, they're supposed to get less complications. So to summarize, use 300 glargine or the Gen 2 basal insulins, if I just group them together. They're effective for sustained glycemic control, the safe, laser overall and nocturnal hypoglycemia, minimal weight gain, stable and prolonged action, and you get some flexibility in dosing time. Thank you very much. I had that much to say. If you have any question, I'll be very happy to share.
Thank you for such a lovely talk. Before I request Dr. Jha to conclude the session, we'll go for the floor. Any question or any remark? Shrutinatha, please.
Wonderful talk. Just two small comments, question. One is patients on glucocorticoids, particularly as a part of chemotherapy, if they get short courses of glucocorticoids, 3, 4, 5 days, and usually they are given dexamethasone, which peaks in about 6 hours, which kind of matches the profile of NPH in the morning. So I still find them useful to use a shot of NPH for those 5-6 days post-chemotherapy. So your comment on that.
Certainly. I mean, there are certain situations when NPH is still very, very handy. If the person is getting, say, short-acting glucocorticoid, like Visolon or prednisolone, the blood sugar goes up all the way till evening and comes back again to normal the next day morning. So if you're given one NPH in the morning, it can probably stop sugar from going up. If a person is getting RT feed, relative feed, and majority of the time they are not getting any feed for 6-7 hours in the night. So they're getting feed over the day, no feed from say midnight to 6 o'clock in the morning. There, NPH insulin works because you want a cover for 12 hours only. So intermediate acting insulin is very helpful in those situations. Yes.
Thank you. Can I have one more comment? To celebrate the 100 years of the discovery of insulin, Nature Reviews Endocrinology brought out a volume, entire volume on insulin. And Earl B. Harsh, who is the editor-in-chief of Diabetes Technology and Therapeutics, discussed the long-acting insulin evolution in that volume, where he mentions in one area that because of its slow absorption, Toujeo cannot be exchanged for Lantus dose for dose. The requirement is some 10 to 20% higher. Yeah. And the reverse happens when someone is switched back from Toujeo to Lantus. You have to down titrate the dose, otherwise there is a real risk of hypoglycemia. So your comment on that.
Yeah, that's
Thank
true.
you.
That's true. Yeah. Thank you very much for your comment.
Thank you, Dr. Roy. And as Sir has rightly said, we are celebrating 100 years of insulin therapy. And Dr. Roy has mentioned about the progress of science. We have blessings of science. We have newer drugs. We have long-acting, ultra-long-acting. In future, we will have. But the crux of the story is still 70% population of India is not controlled. We do not have HbA1c of 7%, less than 7% among most of our patients. So we need to talk about it. We need to initiate more patients under insulin cover, or at least we need to target the patients who needs to have good control, that is HbA1c less than 7, with any drug or maybe insulin, the newer insulins. Thank you so much.
Thank you so much, Speaker Sir and Chairpersons. I would request you to kindly stay back for the felicitation. We are giving a small token of appreciation from welfare organization Sangbedan. Chairpersons, I would like to request you to kindly felicitate Dr. Subir Ray. And